disorders continue. Lymphoid cells constitute the immune system of the body. These cells circulate in the blood and also lie in the lymphoid tissues and undergo differentiation and maturation in these organs. Within the large group of lymphomas, Hodgkin lymphoma is segregated from other forms, which constitute the non-Hodgkin lymphomas. Hodgkin lymphoma has distinctive pathologic features and is treated in unique fashion. Another special group of tumors include plasma cell neoplasms. These most often arise in the bone marrow and only infrequently involve lymph nodes or the peripheral. The clinical presentation of lymphoid neoplasms is most often determined by the anatomic distribution of disease. Two-thirds of non-Hodgkin lymphoma and virtually all Hodgkin lymphomas present as enlarged non-tender lymph nodes, often more than 2 centimeters. The current WHO classification scheme uses morphologic, immunophenotypic, genotypic, and clinical features to sort the lymphoid neoplasms into 5 broad categories according to cell of the body. These are as follows: precursor B cell neoplasms, that is the neoplasm of B cells. Peripheral B cell neoplasms, neoplasms of mature B cells. Precursor T cell neoplasms, that is the neoplasms of mature T cells. Peripheral T cell and NK cell neoplasms, that is the neoplasm of mature T cells and NK cells. Hodgkin lymphomas, that is the neoplasm of redistributed cells and variants. It's the most important topic. Few other important points like overall frequency of these lymphomas. 5 major forms of lymphoid malignancies are their relative frequencies are raised and low. Non-Hodgkin lymphoma is 62% from most common lymphoma. Hodgkin's disease seen in 8% of the population. Plasma cell disorders, 15% cases. CLN, that is a chronic lymphocytic lymphoma, 9% cases. Most common is lymphoid leukemia, most common lymphoid leukemia. And acute lymphoid leukemia seen in 4% of cases. Most commonly seen in the children. Amongst non-Hodgkin lymphomas, diffuse B-cell lymphoma is most common with 31% frequency, followed by follicular lymphoma. Majority of the lymphoid malignancies are of B-cell origin. That is more than 75% of lymphoid leukemia and 95% of the lymphomas, while remaining are T-cell malignancies. The diagnosis of lymphoma, both Hodgkin's as well as non-Hodgkin's, can only be reliably made on examination of lymphoid biopsy, while the initial diagnosis of ALL and CLL can be made on peripheral blood history or CBC examination. Hodgkin's disease primarily arises within the lymph nodes and involves the extranodal sites secondarily. This group comprises about 8% of all cases of lymphoid neoplasms. The incidence of the disease has bimodal peaks. One is seen in young adults between the age of 15 and 35 years, and the other peak after 5 decades of the life. The classical diagnostic feature is the presence of redistributed cells or Dorothy redistributed cells. Unlike non-Hodgkin lymphoma, there is only one universally accepted classification of Hodgkin disease, that is Reich classification, adopted since 1966. Reich classification divides Hodgkin disease into four types: lymphocyte predominance type, nodular sclerosis type, mixed cellularity, and lymphocyte depletion type. However, the WHO classification of lymphoid neoplasms divide into Hodgkin disease into 2 main groups. The one is nodular lymphocyte predominant Hodgkin disease, that's a new type, and the classic Hodgkin disease, which includes all the 4 above subtypes that are classified in the Reich classification. There are several morphologic variants of redistributed cells which characterize different histologic subtypes of Hodgkin's disease. Classic RS cells, RS, polypid or popcorn or LS type RS, and the pleomorphic RS cells. Now, classic RS cell is a large cell which is characteristically a bilobed nucleus, appearing as a mirror image of each other, but occasionally the nucleus may be multilobed. Each lobe of the nucleus contains a prominent eosinophilic infusion-like nucleoli with a clear halo around it, giving an owl-like appearance. The surface of cell is abundant and amphiphilic. Lacunar type RS cells. It is a smaller and in addition to above features has very cellular space or lacuna in which it lies, which is due to architecture shrinkage of the cells at the. It is characteristically found in nodular sclerosis, variety of Hodgkin disease. Polypoid type or popcorn or lymphocytic histiocytic, that is L and H RS cells are seen in lymphocyte predominant type of Hodgkin disease. This type of RS cell is larger lobulated nucleus in the shape of popcorn. Pleomorphic RS cells are a feature of lymphocyte depletion type. These cells are pleomorphic and atypical nuclei. Immunophenotyping of RS cells reveals monoclonal lymphoid cell origin of RS cells from B cell of the germinal center in most subtypes of the Hodgkin's disease. RS cells in all types of Hodgkin disease except in lymphocyte predominance type express immunoactivity of CD15 and CD30. RS cells in lymphocyte predominance type, however, are negative for both CD15 and CD30, also CD20. Grossly, any lymph node group may be involved, but most commonly affected are the cervical, supraclavicular, and axillary groups. Initially, the lymph nodes are discrete and separate from one another, but later the lymph nodes form a large mutant mass due to infiltration into the surrounding connective tissue. The section surface of the involved lymph nodes or external organ involved appears gray-white and fish flesh-like. Presence of necrosis and motility depends on the type of Hodgkin's lymphoma. Lymphocyte predominance type. Lymphocyte predominance type. The lymphocyte predominance type of Hodgkin disease characterizes proliferation of small lymphocytes administered with a varying number of histiocytes forming nodular or diffuse pattern. Nodular form is characterized by replacement of nodal architecture by numerous large lymphocytic nodules. Diffuse form does not have a discernible nodules, but instead there is diffuse proliferation of cells. Nodular sclerosis type, classical HM failure. This is the most common form of Hodgkin lymphoma, constituting 65 to 70% of the cases. It is characterized by the presence of lacunar variant of Reed-Sternberg cells and the deposition of collagen bands that are divided into that divide involved lymph nodes into circumscribed nodules. The fibrosis may be scant or abundant. The Reed-Sternberg cells are found in polymorphous background of T cells, eosinophils, plasma cells, and macrophages. Diagnostic Reed-Sternberg cells are often uncommon. Mixed cellularity type. This form of Hodgkin lymphoma constitutes about 20% to 25% of the cases. Involved lymph nodes are diffusely effaced by heterogeneous cellular infiltrate, which includes T cells, eosinophils, plasma cells, and benign macrophages, administered with Reed-Sternberg cells. Diagnostic RS cells and molecular variants are very plentiful. The RS cells are infected with EBV in about 70% of the cases. Lymphocyte rich type. This is an uncommon form of classic Hodgkin lymphoma in which reactive lymphocytes make up the vast majority of cellular infiltrate. In most cases, involved lymph nodes are diffusely effaced, but vague nodularity due to presence of reservoir B cell follicles is sometimes seen. This entity is distinguished from the lymphocyte predominance type by the presence of frequent mononuclear variants in diagnostic Reed-Sternberg cells with a classic immunophenotypic profile. It is associated with EBV in about 40% of cases that have basic very good to excellent prognosis. Lymphocyte depletion type. This is the least common form of Hodgkin lymphoma, accounting for less than 5% of the cases. It is characterized by paucity of lymphocytes and the relative abundance of Reed-Sternberg cells, or the pleomorphic variants, the immunophenotype of Reed-Sternberg cells, identified in other classic types of Hodgkin lymphoma. All histologic subtypes bigger features are histologic subtypes of Hodgkin disease, except the nodular sclerosis variety are more common in bears. Most commonly, patients present with painless, movable, And from lymphadenopathy, the cervical and intestinal lymph nodes are involved most frequently. Other lymph nodes groups like axillary, inguinal, and abdominal are involved sometimes. Approximately half the patients develop splenomegaly due to the course during the course of the disease. Liver enlargement too may occur. Constitutional symptoms, type B symptoms are present in 40% of the cases. The most common is low-grade fever with night sweats and weight loss. Other symptoms include fatigue, malaise, weakness, and pruritus. Hematological findings की बात की जाए तो moderate thrombocytic and hemoglobin anemia is present. Serum iron and TIBC are low, but marrow iron levels are normal or increased. Marrow infiltration by the disease may produce marrow failure with leukocytic reaction. Routine blood counts reveal moderate lymphoid reaction. Cases with pruritus, recurrent tissue peripheral eosinophilia, advanced disease associated with absolute lymphopenia. Platelet count is normal and increased. ESR is variably elevated. Now, when we talk about B cell, CLL, or SLL, that is a chronic lymphocytic leukemia or the small lymphocytic lymphoma, it occurs more commonly in the middle and older age groups over 50 years of age with a metric tolerance. Metric ratio is more than is approximately 2:1. Features of anemia such as gradually increasing weakness, fatigue, and dyspnea. Enlargement of superficial lymph nodes is a very common finding. The lymph nodes are usually symmetrically enlarged, discrete, and non-tendrous. Splenomegaly and hypermegaly are usual. Hemorrhagic manifestations are found in case of CLL with thrombocytopenia. Susceptibility to infections, particularly of respiratory tract, are common in CLL. Less common findings are mediastinal pressure, tonsillar enlargement, disturbed vision, and bone and joint pains. When we talk about the morphology, the lymph nodes are diffusely effaced by predominantly small lymphocytes, 6 to 12 microns in diameter, with round, slightly irregular nuclei, consists from and scan cytoplasm. Admixed a variable number of larger activated lymphocytes that often gather in loose aggregates referred to as proliferation centers that contain mitotically active cells. When present, proliferation centers are pathognomic of CLL and SLL. The blood contains variable numbers of small round lymphocytes with scant cytoplasm. Some of these cells are usually disrupted in the process of making smears, producing so-called small cells, which are characteristic for the lymphoproliferative disorders. In almost all cases, the bone marrow, spleen, and liver are also involved, albeit to widely varying degrees. Follicular lymphoma की बात की जाए तो follicular lymphoma is strongly associated with chromosomal translocations involving BCL2. It is the hallmark is 14-18 translocation that juxtaposes the IGH locus present in the chromosome 14 and the BCL2 locus in the chromosome 18. The T translocation 14-18 is seen up to 90% of the follicular lymphoma and leads to overexpression of the BCL2. BCL2 antagonizes apoptosis and promotes survival of follicular lymphoma cells. When we talk about the morphology, in most cases, the nodular and diffuse growth pattern is observed in involved lymph nodes. The two principal cell types are present in varying proportions. Small cells with irregular nuclear contours and scintillatum refer to centrocytes, whereas larger cells with open nuclear containing several nuclei and modest amount of cytoplasm refer to centroplasts. In most follicular lymphomas, centrocytes are in majority. In most follicular lymphomas, centrocytes are in the majority. Diffuse large B-cell lymphoma is the most common form of NHL. Common pathogenic mechanism is dysregulation of BCL6 gene, a DNA binding gene finger transcriptional repressor that is required for the formation of normal germinal centers. About 30% of the DLBCLs contain various translocations that have in common a breakpoint of BCL6 at chromosome 3 to 27. Acquired mutations in BCL6 promoter sequence that abrogate BCL6 autoregulation are seen even more frequently. When we talk about the morphology, the common features are relatively large cell size, usually 4 to 5 times the diameter of a small lymphocyte and the diffuse pattern of growth. Motor morphologic features show substantial variation. Most commonly, the tumor cells have a round or oval nucleus that appears vesicular due to vargination of the chromatin to the membrane. But large multilobated or irregular nuclei are prominent in some cases. Nuclei may be 2 or 3 number and located adjacent to the nuclear membrane or single and centrally placed. Cytoplasm is usually moderately abundant and may be pale or vesicular. बात करें Burkitt's lymphoma की, it is also an important topic for the MBBS level. Burkitt's lymphoma leukemia is an uncommon tumor in adults but comprises about 30% of the childhood lymphomas. There are 3 subgroups of Burkitt's lymphoma: African endemic, sporadic, and immunodeficiency associated. African endemic is associated with EBV infection, that is Epstein-Barr virus infection. Sporadic is more pleomorphic and immunodeficiency is associated with HIV virus. All forms of Burkitt lymphomas are associated with translocation of the MYC gene on chromosome 8 that led to increased MYC protein levels. It involved tissues. The involved tissues are replaced by diffuse infiltrate of intermediate size Lymphoid cells 10 to 15 micron in diameter with around 1 nuclei, coarse chromatin, several nuclei, and a moderate amount of cytoplasm. The tumor exhibits a high mitotic index and contains numerous apoptotic cells. The nuclear membranes of which are phagocytosed by the interspersed behind macrophages. These phagocytes have abundant clear cytoplasm, creating a characteristic starry sky pattern. When the marrow is involved, aspirates reveal tumor cells with slightly clumped nuclear chromatin, 2 to 5 distinct nuclei, and royal blue cytoplasm containing clear cytoplasmic vacuoles. Immunophenotype: these are tumors of mature B cells that express surface IgM, CD19, CD20, CD10, and B cell 6. Here is a leukemia, again a small topic, but important for the short answer questions. Rare but distinctive B cell neoplasm constitute about 2% of all leukemia, that is predominantly cases of middle-aged white males with median age of 55 and a male to female ratio of about 5:1. Hairy cell leukemia is associated in more than 90% of the cases with activating bind mutations in the serine threonine kinase BRAF, which lies immediately downstream of RAS in the MEK signaling cascade. This is also important when we read about thyroid. Hairy cell leukemia derives its picture name from the appearance of the leukemic cells, which have fine hair-like projections that are best recognized under the phase contrast microscope. On routine peripheral blood space, hairy cells have round, oblong, or uniform nuclei and moderate amounts of pale blue cytoplasm with thread-like or bleb-like extensions. The number of circulating cells is highly variable. The marrow is involved by a diffuse interstitial infiltrate of cells with oblong or retiform nuclei, condensed chromatin, and pale cytoplasms. Because these cells are enveloped in extracellular matrix, clinical difficulty referred to as a tri-type and are seen only in the marrow biopsies. The splenic red pulp is usually heavily infiltrated, leading to the obliteration of white pulp and a beefy red rose appearance. The hepatic potentials are also involved frequently. Clinical manifestations result largely from infiltration of the marrow, liver, and spleen. Splenomegaly, often massive, is the most common and sometimes the only known physical finding. Hepatomegaly is less common and not as marked. Is rare. When we talk about the peripheral T cell malignancy, following diseases, mycosis fungoides, Sézary syndrome, adult T cell lymphoma or leukemia, and a plasmablast T cell or NK cell lymphoma. Plasma cell disorder, again an important topic. The plasma cell disorders are characterized by abnormal proliferation of immunoglobulin producing cells and result in accumulation of monoclonal immunoglobulin in the serum and urine. The group comprises the following 6 disease entities: multiple myeloma, localized plasmacytoma, Waldenstrom's macroglobulinemia, Henrichon disease, primary amyloidosis, and the monoclonal undetermined significance, that is MGUS. When we talk about the multiple myeloma, it is a plasma cell neoplasm commonly associated with lytic bone lesions, hypercalcemia, renal failure, and acquired immunodeficiencies. Multiple myeloma primarily affects the elderly, and the peak incidence is appears to significant of the life and increases in incidence with age, which is rare under the age of 40. Myeloma is more common in males than females. Myeloma affects principally the bone marrow, though during the course of the disease, other organs are also involved. Divided in osseous lesions and non-osseous lesions. Osseous bone marrow lesions, in more than 95% of the cases, multiple myeloma begins in the bone marrow. In majority of the cases, the disease involves multiple bones. By the time the diagnosis is made, most of the bone marrow is involved. Most commonly affected bones are those with red marrow, that is skull, spine, ribs, and pelvis, but later long bones and limbs are also involved. The lesion begins in the medullary cavity, erodes the cancellous bone, and ultimately causes the destruction of the bony cortex. Radiographically, these lesions appear as punched out, rounded 1 to 2 cm defects in the affected bone that are the lentic lesions, characteristic feature of the multiple myeloma, described under a CRAB, hypercalcemia, renal disorder, but bone lytic lesions. Grossly, the normal bone marrow is replaced by soft, gelatinous, reddish pattern. The affected bone usually shows smoker or diffuse osteoporosis. Microscopically, the marrow contains an increased number of plasma cells, which usually constitute more than 30% of the cellularity. The plasma cells may infiltrate the intestine in a subtle fashion and completely replace the normal elements. Like their benign counterparts, malignant plasma cells have a perinephral clearing due to the prominent Golgi apparatus and eccentric plus nuclear. Relatively normal appearing plasma cells, plasmablasts with vesicular nuclear chromatin and a prominent single nucleoli or desire multiple cells with chromatin. Other cytologic variants stem from the disaggregated synthesis and excretion of the immunoglobulin, which often leads to intracellular accumulation of intact or partially degraded protein. Such variants include fem cells with very red cytoplasm, very important. Mode cells, again very important, with multiple red-like cytoplasm droplets, and cells containing a variety of other inclusions, including fibrils, crystalline rods, and globules. The globular inclusions are referred to as vessel bodies and liquid bodies. Extraosseous lesions in the blood may approximately 50% of the patient with multiple few epithelial bodies in the blood. The other changes which are seen in the blood and myeloma are presence of anemia, Erythropoietic obviously marked red cell formation due to hypersensitivity of blood and elevated. Myeloma kidney, the main mechanism of myeloma kidney is the filtration of the light chain proteins known as Benz Jones proteins, which are precipitated in the distal convoluted tissues, a combination of 10 host-point protein. And then secreted in tubular cast. The cast may be surrounded by some multinucleated giant cells and few inflammatory cells. Myeloma neuropathy system are the diagnosis of myeloma is made by a classic triad of features. Neuroplasmocytosis of more than 10% of the radiologic evidence of fatigue lesions, demonstration of serum and non-urinary component. There is rise in the total serum protein concentration due to the paraproteinemia of normal serum antibodies and immunoglobulins. Paraproteins are abnormal. Immunoglobulins are their parts separating in plasma and excreting urine. About 2/3 cases of myeloma excrete Benz Jones protein and the light chain proteins in the urine consisting of either kappa or lambda light chains. Along with presence of Benz Jones proteins in the serum. On serum intervals, the paraprotein usually appears as a single narrow homogeneous component, most commonly in the region of